It's a privilege to be here with you guys today. I'm sure you're all bursting to the seams with knowledge already. I think my affiliations are not an issue. I don't have conflicts of interest. Okay, so when I got the topic, the medical management of the critically ill, that's extremely broad. In fact, that's basically what you do for 1.5 years of your critical care. So I always revert to Jean-Louis Vincent's article about giving your patient a fast hug when I don't exactly know what to focus on. So, and that's what I teach my registrars as well on day one when they're terrified in ICU. So the fast hug, at least once a day, basically relates to the things that we need to just keep a check on in ICU, which is really fluids, analgesia, sedation, thrombo prophylaxis, the position of the patient, ulcer prophylaxis, and glucose control. So I thought I'd focus on those things and maybe just a few other aspects that we look at. So we're going to look at fluid management. I think for us as intensivists, the paradigm shift has been enormous in terms of how we manage patients with fluids, sedation practices, thrombo and ulcer prophylaxis, glucose control, mobilization and animation, which is becoming increasingly important in our units, and then sepsis, both antibiotic and other resuscitation. And then I'd just like to take a minute to look at what happens once the patient actually leaves critical care or the ICU. Because for many of us, the success story is when they're wheeled out alive, but the long-term outcomes might not be the same. So I'm going to start with fluid management. So as I've said to you, the paradigm shift. They used to say, watch them swell and they get well. This was before my time, giving my age away there. But we used to kind of accept fluid overload as something that happens in ICU. The patient is resuscitated, they swell, they're edematous, they're leaky, and we sort of dealt with it. But the whole premise of why we give fluid comes in the context of shock. So I don't know how many of you can race back to physiology and how far ago that was for you, but you all remember the Frank-Starling curve from physiology. If I increase my preload, then maybe my stroke volume increases and thereby my blood pressure increases. What's very interesting is what we've learned in critical care. Yes, that is true. You can increase patients' blood pressure with fluid, but especially in the context of somebody who has septic shock, which is really where we struggle with fluids. As soon as you reach that point of plateauing on that curve, which means I give more fluids without too much of a positive result in terms of blood pressure, I certainly start drastically increasing fluids in other places where I don't want it. And this is what's really brought about the paradigm shift. So Paul Marek, for those of you who are avid followers of the critical care literature, is probably one of the most controversial intensivists, which is why I absolutely love his work. And they've done a very nice overview of fluid balance and outcome. And if you actually go look at the literature, if our patients have a positive fluid balance as early as 12 hours, you're actually starting to see negative outcomes. And he's divided this into a very nice phase, and this is what we're currently trying to adhere to, is to try and get your cumulative balance as low as possible, to limit your intra-abdominal hypertension, to limit organ swelling, because all of that has effects. You can't feed a gut that is swollen. You can't expect a kidney that is swollen to produce an adequate output. And once again, reiterating that there's worse outcomes once you start having these positive balances. So what we're looking at now is an acute resuscitation phase, limiting in that period, and then actually getting to a stage when the patient's stable, we will actively try and get rid of fluid if the patient is in positive balance, which is quite a paradigm shift for us. This is a busy slide. It's basically just to reiterate what fluid overload does in the body. So there's actually not an organ system that isn't adversely affected. So if you've got myocardial edema, you can imagine that the conduction system is, you're going to start getting more dysrhythmias. Your filling pressures are higher. If you've got a congested heart, immediately that heart can't relax. There is gastrointestinal system, which I think for most of the audience would be quite important. If you start getting gut edema, you're going to get malabsorption, you're going to get more ileus, you're going to struggle to get the patient enterally fed, and then you get more and more renal edema, you start getting more renal failure, and of course your ventilation becomes more and more difficult because you have lungs that are filled with fluid. So really what we're looking at is a bit of a vicious cycle where you have a patient who's hypotensive, they get a fluid bolus. This fluid leaks into the organs, you get intra-abdominal hypertension, The pressures start falling again, the organs start dysfunctioning, and traditionally what we do is why not add some more fluid? And you start getting into a vicious cycle. So what we're doing nowadays in terms of fluid is we're actually trying to get rid of it with what we call PAL therapy. So basically that is some positive pressure, ventilation, some albumin, and then gentle diuresis. So we're doing the opposite of what we were doing a couple of years ago. And then, of course, we cannot possibly talk about fluids without mentioning the FEAST trial. I don't know if anybody's familiar with the FEAST trial. So this was a trial, and I'm particularly proud of this trial because it's a trial from Africa, and it won the Nobel Prize. Came out in 2011, and what Catherine Maitland did is she looked at children with septic shock. And I think everybody in this room is aware that the first thing you do in a patient with septic shock is you try a fluid bolus. It's kind of like standard. Some of my registrars keep trying that for way longer, but it's certainly the first step. And she looked at not giving fluid boluses. Now you can imagine through the average European Ethics Committee this would be a problem. This was a study done in Kenya, and it was related actually partly to resource and availability of IV lines, of IV fluids. And the shock of this trial was the kids who didn't get the fluid boluses were more likely to survive. This has actually gone to challenge the entire surviving sepsis guidelines, which advocates 30 mL per kilo of fluid initially. There are obviously many things we have to consider. Firstly, these were kids, so maybe adults are a bit different. The major second thing that was said about her trial is maybe all the other fluid trials or surviving sepsis guidelines come from a European setting. Maybe we should start actually looking what's happening in our patient population with our genetics and our diseases. Completely different profile. But this certainly caused quite a stir in the critical care community, and there's now major calls for trials to see whether we should be using fluid as liberally at all. Okay, so the amount of fluid is certainly something we've addressed, but we're also starting to address what kind of fluids we gave. So in the initial studies of Emmanuel Rivers, he advocated if you're septic shock, everybody gets hemoglobin of 10. Doesn't matter how you're perfusing, what everybody gets transfused up to 10. We've become a little bit more eloquent with that. Then we went through the stage with heterostarches, which have shown their own issues. Then we went to maybe we should be using crystalloids. From crystalloids, we went to should we be using a balanced solution instead of a very acidotic solution, which is normal saline. And I think now in 2019, we're in the era where we're looking at pH and patients and precision care, individualized care, where we're actually matching fluids as a drug. And this is also quite a paradigm shift, I think, in the medical management of critically ill patients, is to say, give some fluids. That is not a standard order anymore. We should be prescribing our fluids both in amount and in content tailored to that specific patient. And that often changes. Over a course of an ICU stay, my patients will go through the different types of fluids, depending on their needs. Okay, so this is just for interest's sake. Basically, if you have a patient who's requiring large volume resuscitation, look at their pH. If this is a patient you need to alkalinize, then, well, take a fluid with bicarb. If this is a patient who you need to acidify, who's lost a lot of hydrochloric acid, for instance, then saline is probably okay in this case. For the majority of patients, you're going to go for a balanced solution that looks as close to plasma as possible. Right, the second thing we need to look at, which has undergone a major change in critical care, is sedation. So even when I was a registrar, and it wasn't that long ago, we had sleeping patients in ICU. That's kind of the way it was. We let them sleep through their critical illness, then we woke them up. Then when they wouldn't woke up, we scanned them. Then we waited a few more days for our sedation to wear off and realized that they didn't have some brain injury. It was just our doses of sedation. Then when they finally did wake up, they were delirious, and we got them through that, and then we extubated them eventually. We're not kind of doing that anymore. And I think the landmark trial, this is not new, it's old. It's 2000, but the CREST trial was certainly where the paradigm shift started, where they looked at daily interruption of sedation. Again, most of our critical care trials don't show a change in mortality. There are various reasons for that. I think hardly any of the cardiologists will do a trial in cardiac disease, right? They're not going to include valves, ischemic heart disease, but we do that in critical care. We say the critically ill patient is everything from the 80-year-old with pneumonia to the 50-year-old gunshot wound in shock. So it didn't show mortality difference, but it did show that you got out of ICU quicker. You were 3 days earlier likely to be extubated, which is significant, especially if we take our current milieu in ICU. We have multi-drug resistant organs. ICU is not a benign place to be in. If nothing else, this trial started a paradigm shift because it also proved that it's not dangerous for us to start waking patients earlier. And in 2019, what are we doing? Every single day, we want to see if we can liberate a patient off the mechanical ventilation that we're giving them. If it is safe to do so, the patient will go in a wake and breathing trial every day. We will look very carefully at our choice of sedation. We will monitor for the delirium that occurs. And in a lot of patients, we all know the screaming patient who's trying to pull out his tube and swearing at everybody and thinks he's being murdered. That's easy delirium. It's that quiet old lady in the corner with a hypoactive delirium who's actually completely not with you, which is the ones we tend to miss. And then certainly the early mobilization and exercise, because if a patient is awake, they can be animated and they can be mobilized. And I think this is what we strive for in most of our ICUs, wherever possible in 2019. So if we look at the summary of the evidence, unfortunately the evidence has told us that lots of sedation is bad. It hasn't told us too much about what we can do when the delirium does set in. But certainly what we do know is that we should titrate our medications to use the lowest possible dose. All we want is to keep patients comfortable and safe. We don't want to provide good night rest for the entire unit who's working night shift. All right. We want to use protocolized care. And by that I mean if a patient is running a sedative, we want to actually measure where is he at? Is he still agitated? Can I decrease it? Where do I want to target my sedation to? We still use propofol quite widely, but certainly the new kid on the block, or not so new anymore, is dexmedetomidine, and there's lots of trials coming out on that. And we try to interrupt sedation if we can't use it as boluses. And every day you should certainly, as part of what you're looking at, review the patient's sedation. I was heavily criticized in the last physician exam for asking the first step of delirium management, because only 10% of candidates actually got it right. We don't think of pain often enough in ICU. So the first step of a patient who is delirious, or if you want to address possible sedation, is actually to make sure that they've got adequate analgesia. You want to avoid deep coma if at all possible. If the patient has status epilepsy or has ARDS and you're paralyzing them, then we will certainly allow for coma. We also tend to forget liver and kidney function in ICU. Our sedatives stick around a lot longer, and we want to aim for spontaneous breathing, as I've said. So this year there was a trial, the DEXA trial, and this was the combination of dexmedetomidine and acetaminophen. So like I said, lots of data coming out on dexmedetomidine in hyperactive delirium. The idea of conscious sedation is a very eloquent one for us in ICU because the patient can still breathe. I can even extubate him on conscious sedation, and he is calm and restful. So what they actually looked at, it wasn't a massive trial. They had about 30-odd in each arm, and they looked at placebo or paracetamol, good old paracetamol, right, with dexmedetomidine and propofol in different combinations. And what they actually looked at, the primary endpoint, was to see, does the use of paracetamol affect delirium? And they had quite a significant result, because a statistically significant, and you have to know it must be a really good effect if you're going to get a statistically significant result with 30 patients in each group. Less number of patients had delirium. And if you go and read the fine writing again in this trial, you'll realize that if you were giving good pain control with paracetamol, which is the GP's choice, it's not usually the intensivist's choice, certainly you were getting better pain control, you were sparing your morphine, which is deliriogenic, and you were probably using less sedatives altogether, because many patients aren't cuckoo because of anything else but the fact that they can't tell you they've got pain. So an interesting trial, and I think a large randomized controlled trial is being set up. Okay, one of the other things that seems so obvious in ICU, but apparently we are actually still doing quite poorly, is thrombo prophylaxis. So we all fear the dreaded pulmonary embolism in our patients. Generally, if you look at the general population, all of us sitting here today, your risk factors are pretty standard. Age, past history of embolism if you've got active cancer, immobilization, obesity, pregnancy, trauma, stroke, recent surgery. And what our data is now showing very clearly is that HIV should be in there too. Just the fact that a patient is HIV positive certainly increases your risk. But in ICU, we have numerous other risk factors. So sepsis in itself, there's very good interaction or very good evidence to show the interaction between coagulation and inflammation in sepsis. And the two kind of go hand in hand. In fact, there are now studies showing that TEG, which is basically a measure of coagulation, your TEG will probably be abnormal before your CRP in early onset of sepsis. We use vasopressors, which in themselves are associated with DVTs because we usually give them through central lines. Respiratory and cardiac failure, sedation once again, mechanical ventilation, and renal failure. All of these are additional risk factors for venous thromboembolism. Again, a busy slide. This is basically just to show you that the earliest evidence for deep venous thrombosis in ICU actually comes from 1982. And to this day, we're still showing that even despite awareness and prophylaxis, there's inadequate thromboprophylaxis in anywhere between 20 and 40% of patients, depending on which studies you're looking at. So if you look at death, which is quite a hard endpoint in critical care, about 12% of deaths are attributable to venous thromboembolism, which is theoretically preventable. It's certainly in hospital responsible for most preventable deaths. Asymptomatic events occur in, if you read in the studies, very broad. Some studies report up to 80%. That seems excessive. But for most of our data, around 20% of patients will have small emboli that you're not going to even pick up. Silent DVT is present in 5 to 10% of ICU patients, despite thromboprophylaxis, again. And whether or not that is important is difficult to say, because what these trials were doing is they were just routinely screening patients for DVTs. Everybody who's in ICU gets a screen. But it does seem like if you are able to see a clot on Doppler, you are at risk for that embolizing. Even small PEs are very poorly tolerated in our patients because they just don't have the reserve. And if you look at the data, ICU doctors are very often skewed towards the risk of bleeding in critically ill patients when their platelets drop in sepsis. Perfect example is, for instance, liver failure. In liver failure, the INR goes up. Nobody wants to anticoagulate anymore. But they forget that the liver is also responsible for creating your thrombolytic proteins. So those patients are actually often very hypercoagulable, and we tend to overcall it on the risk of bleeding. What about stress ulcers? So stress ulcer prophylaxis is probably one of the most controversial things in critical care. We tend to swing the pendulum. PPIs are life-saving, and then next month they are killing our patients. So at the end of the day, a functional gut is probably your best stress ulcer prophylaxis. If you can establish good enteral feeding, that's probably your best. Upper GI bleeds don't often kill our patients in ICU, but they add significantly to the morbidity. And if you've had an upper GI bleed, you're going to stop your anticoagulation, you are going to transfuse the patient, and all of those have risks of their own. But certainly the drugs we're using in ICU are not without danger. So who really is the patients who are at risk? So anybody in shock, which is quite a significant number of our patients. Any patient who's on anticoagulation, so those cardiothoracic units, certainly that's a huge risk. Patients on renal replacement therapy, just the fact that you're intubated and ventilated puts you at an increased risk. If you've got a history of liver disease or a history of any previous or ongoing coagulopathy. So the question is always to PPI or not to PPI, to give a proton pump inhibitor or not. And your risks really is the risk of a gastrointestinal bleed against the PPIs, increasing ventilator-associated pneumonia and Clostridium difficile. So it seems odd that the PPI would cause pneumonia, but if you think about it, your primary defense in the stomach against bacteria is acid. So if you take that acid away, you get bacterial overgrowth, and our patients silently aspirate despite us thinking that their cuffs are beautifully blown up. you get microaspiration all the time. And those organisms do tend to end up giving you pneumonia, and then the risk of Clostridium. So, once again, trial last year, the pantoprazole in patients at risk for GI bleeding in ICU. They called it the SUP ICU trial. If your trial doesn't have a cool name, nobody remembers it. Quite a big trial. I mean, they randomized 3,298 patients. I loved this. I've got a very sarcastic colleague who does blogs and posts for critical care, and he actually posted this. So he said, SUP, no comment on GI prophylaxis, just saying hi. Because at the end of the day, this trial didn't help us nearly as much as we were hoping. Because they said, no, giving a PPI doesn't prevent death. So my colleague's comment was, okay, how many people actually would need to bleed to death in ICU, where we can pick up bleeds really easily? I mean, it's not like the patient is in some peripheral little ward where nobody's going to notice his HB dropping and the melena stools. So he actually calculated that they would actually need to enroll about 20,000 people to show a mortality benefit. So this trial was geared, it was made for mortality, but it's a stupid design. If you look at the data we did generate from it, is certainly clinically important GI bleeding. Clinically important was defined as the patient actually needed an active intervention. And if a patient needs an active intervention in ICU, if you're in the best ICU, that puts them back a day or two. If you're going to have to stop feeds, if you're going to have to transfuse, if you're going to go for a G-scope, so that was considered clinically significant. And the p-value from that is highly significant. So sure, in patients who are high risk, I'm not saying every knee replacement should get a PPI. That's complete overkill and that's inappropriate. But in patients with those risk factors, clinically important GI bleeding was prevented by a PPI. What I like a lot here is look at the pneumonia. It's almost too perfect. They exactly matched. So those who had the specific PPI, of course it can't generalize, didn't have more pneumonia, and the Clostridium infection was not significantly different between the two, which kinds of swings the pendulum back to favoring PPIs again in the right population. So no, stress ulceration prophylaxis will probably never really affect mortality because we don't allow them to bleed to death in the ICU. In this trial, it did what it was made to do. It prevented significant GI bleeds in high-risk patients. The lack of toxicity, which is widely why we're scared of using the PPIs, was certainly significant, and this would probably favor the drug which was used in the trial. So I think at the end of the day, we need to more clearly define which patients require PPIs rather than throw them out baby bathwater altogether. So I think of particularly for this audience, this would be of importance, is glucose control. So I'm going to divert a little bit, and I'm going to go to the concept of normalization fallacy. I love philosophy and ethics, not that I'm putting them together at all, but just a little bit of the art of medicine sometimes, not just the science. So in critical care, the idea of normalizing everything has certainly proven us wrong. We've tried that with everything. We try and get to perfect blood gases, and then we realize, oops, the things we're doing to the patient to get those perfect blood gases is actually harming them. We aim for perfect glucose, and then we realize, oops, the hypoglycemia we're inducing is actually probably more injurious than the hypoglycemia the patient had. So Scott Aberrake, he's an intensivist in Germany, he basically discusses the normalization fallacy, and he says, if we see an association between an abnormal value and outcome, I always get this, my registrars will always want to correct every value so that the chart looks nice. And I say to them, okay, have you actually touched the patient today? Because that does occur. So there are three possibilities. There's the possibility that this abnormal value is actually causing the harm. Your patient's HB of 5 is actually what's causing him to have heart failure. Therefore, correcting it will improve the outcome. Then there's the second possibility that the abnormal value is actually an evolutionary compensatory process. And I think in critical care nutrition, we're seeing a lot of that. We're seeing that we don't necessarily need to interfere with our physiological processes If that's the case, then correcting this value would actually cause harm. Or, as in the majority of what we see in critical care, they're an epiphenomenon. Yes, if my calcium is low in ICU, I'm more likely to die. Giving calcium to every ICU patient doesn't make them live. So it's an epiphenomenon, it's association, it's not causal. And I think glucose is probably what's really taken us on this journey in critical care. Because if you look at the glucose trials, I think the major trial, the first really, there were some small ones before that, but the Leuven surgical trial, 1,548 surgical ICU patients, they went for tight versus lax glucose control, and what did they find? The ICU mortality was less with intensive insulin therapy. And their in-hospital mortality was less, their sepsis was less, their renal failure was less. It seemed like insulin was probably the answer to just about everything in critical care. There were obviously some issues here. So patients with pre-existing diabetes actually did not benefit. That wasn't clearly illustrated in their results. Patients received high glucose loads. I'm sure I'm speaking to the converted here about this trial. It was a single-center, unblinded study. And the big thing is it wasn't repeated in subsequent trials. And what did we all do after this? Well, not we. I wasn't an intensivist then yet. But what did the critical care communities do is we adopted this onto everyone, and we actually saw that outcomes weren't as favorable. So when they repeated this trial on medical patients, now suddenly there's no reduction in hospital mortality because medical patients are completely different to your surgical patient. If I've got a healthy young male who breaks his femur or gets a gunshot wound, I resuscitate him, he's sorted. My medical patients, oh my word, they left a comorbidity about 5 lines for me on the chart, and I actually said to them, you're going to have to triple that for the average medical patient. So certainly mortality wasn't changed. There was, however, a reduction in renal injury, duration of mechanical ventilation, length of stay. So those are not the primary outcomes, but there's some benefit in controlling the glucose to an extent. And this is really what called for the NICE sugar trial, which again, I'm sure you're all very, very familiar with. Nice big trial, 6,000 patients. It's multi-center, which is always very nice, and it included both medical and surgical. Their primary outcome was mortality, once again, and the intensive control group had increased mortality. So I think that is what changed our practice, brought us back to reality, and they had more severe hypoglycemias. And anybody who's spent some time in ICU knows that a patient who's critically ill tolerates hypoglycemia very poorly. The sympathetic surge that they get causes them to have type 2 myocardial infarctions, they get more dysrhythmias, things just generally don't go well. And here they actually didn't find the difference in the length of stay, ventilation, or need for dialysis. This is our current gold standard, probably our biggest trial, and the majority of us will go for lax glucose control. So if you look at the post hoc analysis of this trial, I'm quite a fan of post hoc analysis. It's not very puristic. But I sometimes think that trials tend to prove a lot of interesting things that weren't necessarily designed to prove. So I like looking at post hoc. Patients with severe hypoglycemia were actually twice as likely to die compared to their counterparts. Patients with intensive glucose control were 10 times more likely to have hypoglycemic episodes, which kind of reverts right back to that sentence over there. Patients with moderate hypoglycemic episode had a 5% absolute greater risk of death. So even what we would consider mild did adversely influence. And this is where that normalization fallacy starts coming in again. There also seems to be a dose-response relationship between hypoglycemia and mortality. So if you've got persistent hypos, you are probably going to die. This, again, might be an epiphenomenon. A patient who is in septic shock, multi-organ failure is obviously more likely to have hypoglycemia, so we should be careful. You should always have the caution that correlation does not actually imply causation. But this has been a practice-changing trial for us, and I think in 2019, very few intensivists will go for tight control unless you have a patient with a continuous monitoring and the insulin pump, not allowing for much human error. Okay, so for me, probably the biggest bugbear in ICU is sepsis. There's various reasons for this. First of all, we really struggle to define what exactly sepsis is. I was in Brussels when the new definition for sepsis was released, And Jean-Louis Vincent, who's basically the father of critical care, I think, at the moment, stood up and said, okay, so the collaborators got together. They realized they needed a publication. So they shoved around some of the words, changed the point here or there, and published this new definition, which isn't going to help anybody. He, of course, did this just before Mervyn Singer presented the actual paper. So it was one of the best debates, controversies. I actually thought physical violence would occur, but it didn't. So that's the first thing. In ICU, so many things mimic sepsis. For us to decide that this is actually sepsis, this isn't necessary, this isn't a PE, this isn't pancreatitis, this isn't an MI, that's your first difficulty. And there's the tendency to rely very heavily on biomarkers. I've often done a ward round, and a registrar will tell me the patient's looking so much worse. And then I get to the room, and the patient's smiling at me, actually reading a book for the first time. And I said to them, what do you mean? And then they said, CRP's up. So we rely very heavily on biomarkers, which is also problematic because many things can influence that. The second thing is superbugs. We have them, and our patients know we have them. Our patients will blame the hospital for them. They cannot understand that when you crowd a whole bunch of sick people together and you use a ton of antibiotics in those patients, that is where the superbugs will be. So these are major issues, and the superbugs have certainly got a lot of media attention. I think there was a National Geographic cover with Candida auris on it and said we're all going to die, which sometimes if I look at auris, it's a possibility. So I'm just going to talk about our management principles of sepsis because I think that's quite important. Most patients during their ICU stay will have some episode of sepsis. You're lucky if you get away without it. So resuscitation in sepsis has changed. Now I alluded to that under the fluids. Early administration of appropriate antibiotics following blood cultures. That is important. So I work with many really good physicians and surgeons, and we did a little audit just to see how many people are actually taking cultures before they prescribe antibiotics. And you'll be absolutely shocked how such an easy, obvious thing is often lacking in our units. Early source control, judicious fluid resuscitation, noradrenaline for refractory shock, it's the choice now, inotropes for septic cardiomyopathy, and then the ongoing supportive care that you need to give during that episode. So fluids for sepsis, we know that the original recommendation was the 30 mL per kilo. I've already alluded to the fact. You can see I'm very passionate about fluids. It's just featuring again. The early goal-directed studies that said we had to put up a CVP, get the HB to 10, give them fluids, look at the mixed venous saturation. That trial was actually proven wrong by 3 subsequent trials. And there were 3 multi-center trials, the ARISE, the PROMISE, and the PROCESS trials, all said that if you have good standard of care, you don't need necessarily to do early goal-directed therapy. I think what happens with early goal-directed therapy or protocols sometimes, and I know there's a place for them, is doctors or whoever, the medical team, their brain switch off when they're following a tick box protocol. And I think that's probably why these protocols don't always work. We now know about fluids. We shouldn't be using the starters in sepsis. We know there might be a place for albumin. The trials are contradictory in severe sepsis. The Albios trial did show no difference in patients with severe sepsis. If you look at the SAFE trial, though, with severe sepsis and septic shock, they seem to be better if you're giving them albumin. Albumin is expensive, but it is a possibility. And then our balanced solutions, like I said, we're tailoring them to the patient's needs. What about our vasopressors and our inotropes? So what is also in Paul Marrick's data is the concept that you don't have to necessarily in early septic shock put up a central line. I tend to keep this quiet from my registrars because they will delay their central lines then by days. There is, however, good evidence that if the patient's well monitored and you're in the early phase and you think you're not going to be putting them on inotropes forever, you can actually give low-dose inotropes through a large bore peripheral vein. The reason I'm mentioning that here is I think that is important in sepsis management because the idea of having to put up a central line for a patient might actually tempt treating physicians to err on giving a little bit more fluid and a little bit more and seeing if you can get away without inotropes. And that's why I've mentioned it here, because you can actually in the first while give the inotropes instead of flooding them with fluids through a large peripheral vein. In 2019, recently published the SENSOR trial. Noradrenaline is our choice of inotrope in the initial phase of septic shock. The reason for this is it's got alpha and beta effects. The beta effects helps with the inotropy, of course. The alpha effects, everybody thinks it's the vasoconstriction on the arterial side, but remember you also get venoconstriction. So if you're constricting your veins, you're actually giving a patient a fluid bolus with his own fluids, and it's fluid sparing. That is why I prefer, and of course the SENSOR trial agrees with me, that we use noradrenaline. The target for mean arterial pressure is also relatively artificial. We generally use 65. Now again, I think we're moving into an era of precision and individualized medicine. If I've got a patient who's generally running a hypertension and their mean is around 90, 65 probably isn't going to be enough. If I've got a 45 kilogram tiny little girl who's passing urine with a MAP of 55, that's probably adequate. So 65 is sort of a rounded off figure. The Sepsis trial in 2014, where they targeted high mean arterial pressures, and the only people who benefited from that, any guesses? The hypertensives. So the hypertensives needed less renal replacement therapy on a higher target, but everybody with a higher target actually got more tachydysrhythmias. So that is atrial fibrillation. What about antibiotic therapy? So I think we all want the recipe that actually works, because we all have a responsibility of stewardship. We are responsible to try and preserve our antibiotics for the greater community, and yet you have a dying patient in front of you. And balancing those can sometimes be tricky. Certainly you need to investigate first. You need to send off your cultures. You need to have an idea with what you're dealing with. My registrars know if they want me to explode and have triplets in the unit, they must tell me the patient has sepsis. No, the patient has pneumonia with septic shock, has urosepsis, but you don't, what is sepsis. Then you should treat early and aggressively and streamline quickly. So we start broad, but as soon as we can, we de-escalate to try and limit resistance. So if you look at your appropriate broad spectrum antibiotics, there's a lot of evidence for it. And the first study was actually Kumar's study, 2006, again an old study, but he showed that in septic shock, for each hour that you delay appropriate antibiotics, you increase mortality by 8%. If you're going to look at that study, there's two things you should note. The septic shock, so it's not every patient who has an infection. The lady with her UTI who's got normal hemodynamics is not going to die if she doesn't get antibiotics now. And the second thing is that it's appropriate antibiotics, which is the really difficult part for our patients to know what is appropriate, because our patients have a lot of contact with healthcare facilities, for instance. We have rehabs, we have old age homes. We're seeing patients coming from old age homes with multi-drug resistant organisms, and they haven't even been in hospital. They're just in the same old age home as the lady who has been in hospital. So certainly your empiric antibiotics should be both syndromic and local. So you have to consider what is happening in your hospital. In my unit, I don't have a major gram-positive problem. If I have to start empiric antibiotics, I'm going to go and cover Klebsiella, Pseudomonas, or the gram-negatives. Some units, gram-positives might be the issue. The other thing that we do in critical care is we adjust the doses. So we do a lot of dose adjustments for two reasons. The patients have low albumin, and a lot of our drugs are albumin-bound, so they tend to filtrate out their drugs through their kidneys instead of maintain it at the site where it's needed. And patients in septic shock tend to hyperfiltrate anyways. Their estimated glomerular filtration rates are very high, so I'm getting rid of my antibiotics quicker. And the third reason is we have more resistant organisms. I can't actually afford to dabble with concentrations of antibiotics that are lower than my minimal inhibitory concentration. Source control. This is probably one of the most difficult things sometimes to attain, and why it gets right back to finding the source initially before you start antibiotics. There is no replacement for nifamycin. If a patient has an abscess, I can pump him full of antibiotics. If my surgeon doesn't bring his scalpel, I'm not going to win. If there is a septic source, a septic line, whatever the case is, that needs to be removed. Often these procedures will be minimally invasive. We try not to take the patient who's in septic shock for a big fat laparotomy, but we can do percutaneous drainage, we can do damage control surgery if needs be, and go and fix the rest later. intravenous or pre-existing devices. If the cardiologist will often tell you, but the patient, it was $100,000 pacemaker. And I said, yeah, well, it's probably the source of sepsis, so it's going to be a 1 million rand ICU stay if we don't remove it. And there's good evidence that if you have a source, you need to get source control within 6 hours if you're going to make a difference to outcome. Okay, so who is aware of the current trending of vitamin C in critical care? It's made a major comeback. So much so that it has upset so many intensivists that I have to wonder, if we're deeply upset by the fact that a silly old vitamin could be achieving more than many of our antibiotics, or what the case is. But there's a lot of controversy around Paul Marrick's formula, which uses high-dose thiamine, high-dose vitamin C, and Solucortef or hydrocortisone in a combination. Basically, the rationale for this is that especially the thiamine and the vitamin C reduce the nuclear factor Kb activation, and that is what is actually responsible for your pro-inflammatory mediators, for the endothelium becoming leaky, for your permeability altering on the level of the endothelium, and for eventually your microcirculatory flow, which relates to tissue flow. So in septic shock, we're moving away from resuscitating the mean arterial pressure and the urine output to resuscitating the microcirculation. In other words, what happens at the level of the tissue? I think for those of you who've worked in ICU, I don't know what all of your backgrounds are, but you've all seen the patients who have a good blood pressure, but they are completely shut down peripherally. They're blue, they're cold, and that's the microcirculation. That means, yes, the blood pressure is there, but at the level of the microcirculation, there's already dysfunction. And that is much more difficult to address. Okay, so watch the space. The randomized control trial is coming. Paul Marrick has published preliminary data, which looks fantastic. I have used this as a referral center. I often get very, very ill patients. We get them late, we get them with multi-drug resistant organisms, we get them in septic shock, and there have been quite a few patients where I'm certain this has changed outcome, but the randomized control trial is coming. This is a factor we've been underestimating, I think, for many years, and it's more than just an annoyance. It's more than just the patient shouting and pulling out his catheter, and this is actually associated with mortality. So you're going to have 3 times the mortality at 6 months if you had an episode of delirium compared to your counterpart who didn't have delirium in ICU. It prolongs your ICU and hospital stay, we all know that. If you self-extubate and you get re-intubated, you win yourself a couple of days more in ICU. What is very concerning is even when they're not confused anymore, when the delirium is sorted and we're all laughing about the crazy dreams that they had, these patients do not go back to their functional state. And at 12 months, half of patients who had delirium, I can still measure their cognitive defects. This becomes really important when you were running a company, when you were running a practice, when you were, whatever the case may be, functionally, when you were a student and you can't go back and do learning, new learning, memory, then that becomes very significant. It also becomes an economic problem because there's greater dependency on the community, on healthcare providers, and of course on placement facilities. Now, South Africa is not that well known for many supporting centres for long-term care. Very often this is the family's responsibility, and that has implications then for a broader community. Your risk factors for delirium, basically, if you look at this, isn't that just the ICU patients? Okay, age and dementia, not necessarily. But Apache scores that are high, mechanical ventilation, those who are acidotic, those who had multiple organ failure, those with coma, basically it's kind of what got you into ICU very often. So, they're a very vulnerable population. The management is also tricky. Certainly if we can prevent delirium, that would be a lot better than trying to cure it. We should be monitoring for it, the literature says. The literature doesn't always tell us what to do when we find it, though. We should not assume that just because the patient's in ICU is why they're going crazy. Right, many patients withdraw. I've had many a patient who had no alcohol history whatsoever, and then the family go, shouldn't you just give him the whiskey he has 2 glasses or 2 tots of every night when he becomes confused? Hypoglycemia, metabolic and endocrine causes. Sometimes patients get confused when they have new sepsis. There could be porphyria that you've unmasked in ICU with all your drugs. So it's important not to assume it's just because the patient's in ICU and yes, they get confused. I think if you look at the literature, your non-pharmacological treatment is not inferior to pharmacological treatment. And this is, again, I spoke earlier about art and science. This is where the art of medicine comes in a little bit again. By doing the little things that seem so silly, you can probably achieve more than with drugs. By telling the patient about day and time, orientating them, getting some sort of sleep hygiene. I don't know if any of you have ever been in an ICU at night, but it's not exactly conducive to sound sleep. Removing their catheters early, involving the family, nighttime noise control. I once had a patient say to me, he is convinced they play bedpan soccer in the unit at night. But that was quite creative. Hearing and vision impairment. You can't believe how Granny perks up when she can actually hear you and see you when you give her glasses and her hearing aid. And these are very simple things we sometimes do neglect. So what about the pharmacological treatment? So if you look at the FDA regulations, there's actually nothing that goes, this is the standard treatment for delirium. And most of the psychiatrists who generally give the delirium lectures will tell you that most of these drugs are actually very toxic to the brain and deliriogenic. Psychiatrists are not the ones that are called at 1 o'clock in the morning for the patient who's extubated himself, bleeding from his arterial line. So we kind of meet them in the middle. If you want to look at anecdotal evidence, some studies, not necessarily randomized controlled trials, thiamine, especially if there's a history of malnutrition or suspected alcohol consumption. My registrars will all prescribe thiamine to just about everybody in the unit, and they do so because their predecessors will tell them, Veronica wants thiamine on script. And then by week 2, I say to them, why are you giving the patient thiamine? And they look at me like, kind of embarrassed that they haven't wondered themselves. But thiamine is one of those things which generally, if you're giving Lasix, if you're giving many of the drugs that we're doing, and certainly for the metabolic resuscitation, is a good drug to have on board. Then what we usually use is the antipsychotics, dexmedetomidine. We decrease the use of sedatives when they are not needed. So doing your sedation right in the beginning is going to save you a lot of trouble with delirium in the end. And then we do tend to use doses of the benzos just to calm the patients when we need to, and then the antipsychotics. By the way, all of the new antipsychotics, there's no evidence that they're any better than good old Serenase and haloperidol. So as long as you use the drugs, limit the duration, and know their side effects, I think that's quite important. Okay, so the ABCDE bundle, you guys will recall a couple of slides back. That does decrease your risk of delirium. I've said to you we should be measuring, we should be having an outcome for the sedation that we do prescribe. First aim is to keep patients pain-free, and then after that, minimal sedation. Early exercise and mobilization decreases your chance of having a delirium. It's a little bit of stimulation for the brain as well. I have a portable DVD player in my ICU, especially for the kids and the younger people. It's incredible. I've seen patients' SATs go up just from watching something that actually interests them instead of just lying on their backs. So if you implement this bundle of early animation and limiting your sedation and early mobilization, you are going to actually see a difference in outcome. So ventilator days decreases, your delirium decreases, and what's very interesting is the literature says there's actually not an increase in self-extubation rates. And when I started implementing this in my unit, trying to move from the sleeping beauty paradigm to an animated involved patient, my sisters kept telling me they're going to call me when the patient self-extubates. And they don't because they're not confused. So if I can explain to a patient and they can write that they have pain, there's generally not actually more occurrences of these things. Once they are delirious, that's a little bit of a different story. Okay, the last point I want to just touch on is what about after ICU? So when I started taking over the unit of medical ICU, I really wanted to do an ICU follow-up clinic. For the life of me, I couldn't get patients to come back. So I phoned them, so the very frustrating part was quite a few of them had actually passed away in the ward, so they didn't make it to hospital discharge. But one day, a patient said to me, can I be honest with you? I associate you with my ICU stay, and I actually don't want to see you again. And then I went to go look at the literature, and this is actually a recurring theme in the literature. So if the ICU doctors do the clinic, patients don't want to come back. If I'm going to offer you a psychologist who you can talk to about the recurring nightmares you're having about me, If I give you a physiotherapist who can help you actually maybe get to the point where you can drive again, they would come. And this is really what we're looking at. The focus has changed from just what's happening in the ICU to what happens afterwards. This is directly quoted from a patient. He says, for him, it's a blurry line between reality and delusions that is the most frustrating aspects of my ICU experience, because these hybrid memories can never truly be resolved. He said he'd keep going to his family, I think somebody attacked me. It was probably the phlebotomist in the morning, to be quite honest, when he was delirious. So he's not sure what was reality, what was not, what really happened to him. And this is very distressing to patients. And this is really sobering. Once a patient is discharged from ICU, and I don't mean the knee replacement who just chilled there for the night so that, we didn't get called from the ward too much. A patient who was really ill, 40% of them will suffer from depression. Not just sad feelings, a DSM-4 diagnosis of depression. Up to 40% have cognitive deficits similar to mild traumatic brain injury. That is significant because if I can't go back to doing my work, that would severely impair my quality of life, even if I am alive. 60% of former ICU patients suffer from anxiety. They say when they come back to the hospital, they get panic attacks. I've seen family members get panic attacks when they enter the hospital. And up to 25% will have cognitive deficits, and probably this was the most shocking part, similar to patients with mild dementia. So all of these little things that we've been talking about in ICU and trying to get them out and trying to get them animated has an effect in the bigger picture. And then you can extend that even beyond the patient himself, and you can look at the family and the caregivers. All right, you can't say I'm giving you outdated data. This was published on Monday. 40 studies that they included in a large review. They looked for psychological outcomes in family caregivers. We are very notorious to only get annoyed with family. We're not really looking after them when we're looking after ICU patients. And there's a huge range in the studies of depression, anxiety, post-traumatic stress disorder, and these were persistent. And if you looked at income in that family, 90% of families who've had somebody that they're looking afterwards after post-critical care suffered loss of income. They tripled their number of hospital visits from that patient, or their doctor visits. So suddenly there's, irritable bowel syndrome and pain and all sorts of things that weren't there before. So really, I think what we do in ICU has far-reaching rippling effects beyond just that day. And that is my story.